Hello and welcome. It is Dr. Wood again here talking about ethics in research. So something you're all going to be doing as soon as you get your white coat ceremony. I know it sounds exciting because you guys are so close to actually having your white coat ceremony. You're going to recite the Hippocratic Oath, and of course the big takeaway that everyone remembers from the Hippocratic Oath is first, do no harm. And that is one of the guiding principles you're going to be finding in the medical literature. So basically, one of the things I wanted to talk about were some of the safeguards that we put in place when performing medical research to try to make sure that we keep the patient in the forefront in terms of safety, in terms of confidentiality, in terms of respect, in order to make sure we treat these people as humanely as possible. And one of the big players with that is going to be the Institutional Review Board, or the IRB. You can actually look this up for Nova. Most institutions will have an institutional review board, and they are really going to be a panel of people who are designated to review all research being done within an organization and determine whether or not they think the study can go forward, right? So basically what they do is their prime priority is going to be making sure that they are ensuring the rights and the welfare of those patients there, right? They want to make sure that no one's being put at undue risk. They want to make sure that the studies are being done humanely and ethically. So what they do is they'll, say for instance, you are going to do a piece of research that you are having involve human subjects. You basically would write a proposal, a protocol. You would submit that to the IRB. They would review it and then come back, and basically they could tell you a few different things. One, yes, you're approved. 2, you are rejected. We don't want you to do this. And then 3 could be, hey, you need some revisions here. And their main role is to try to assist researchers to make sure they're helping to protect their human subjects. So there's a lot of history behind this. I mean, if you look up things like Nazi Germany and some of the really horrible studies they were doing to their patients there, especially those twin studies and things like that. It's really awful. I'm not going to get into the details of that, but it's a good read if you ever want some context for why we do things the way we do today in research. But basically one of the guidelines that we use from something called the Belmont Report is that, for one, we want to have respect for persons, right? So we understand that people are autonomous beings. You can't force someone to be in research if they don't want to be, right? There always has to be the option for them to not participate if they don't want to, right? So you can have a patient who, say, is signing up for a study that's going to be run 10 years long. They can make it to 9 years and 354 days, and they can say, nope, I just don't want to do this anymore. And that's okay, right? They're allowed to leave studies whenever they want to because they're allowed to exercise their autonomy. That also means they need to have informed consent. So whenever you're involving a patient into a study, you have to have them sign off on informed consent, making sure that they know all the details of the study protocol, making sure they know the potential benefits, and they know the potential risk that can happen there. If a study is randomized and they may not actually be getting real drug, you have to let them know that. And that may lead some people to say, well, I just don't want to participate. I don't want to take sugar pills. That's just ridiculous, right? And so because of that, everything is voluntary and we must maintain their privacy, right? So that's part of the big respect for people that we have to maintain when doing medical research there. The next important point here is beneficence. Basically, this means we're trying to protect subjects from harm. That means you need to, with your study design, make sure you're trying to maximize the benefits while trying to reduce any particular risk that you can. Now, for instance, if I'm trying to study a new drug, there's probably going to be side effects that we don't know about, right? And you have to warn patients about that, hey, there could be a 1 in a million side effect that could happen to you. We just don't know what can happen, right? Now, this really helps to inform what the research design is going to be. So as a good example, imagine you were trying to study a new drug for HIV, right? Now, say you want to do a randomized controlled trial where you're going to have patients be either randomized to your new experimental drug or you randomize them to control. Well, what is the control in this case? Well, is it ethical to, say, take patients off of all their other HIV medication and have them take placebo? Well, of course not. That's ridiculous, right? Because we know what the potential downsides and what the potential risks of patients not receiving their heart therapy, right? We know all the different bad things that can happen there. So in those cases, oftentimes you may find that the control is going to be the gold standard therapy for something, right? So you would keep a patient on gold standard sort of HIV regimens, and then for your controls, and then in the experimental group, they would get the new drug, right? Also, you have to make sure you're having competent investigators. You wouldn't want random podiatrists doing, say, cardiac surgery or something like that, right? So it needs to make sure you have competent people who are running these investigations. And then looking for favorable risk versus benefit analyses. Now, again, there's a lot we don't know when we perform research, but we're trying to maximize the benefits to our patients while minimizing the risk as best we can. And then there's justice, right? Basically what this is referring to is the fact that the benefits and burdens we might be imposing on patients with our research has to be spread equally, right? So this is why patients may get randomized to different arms of a trial, right? You don't want to, say, have any sort of favoritism or introduce any bias by saying, well, if you pay me an extra $5, I'll put you in the experimental group, right? I'll give you the actual drug, right? You can't do things like that. Patients have to truly be randomized. Now, does that mean you can't pay people to be in a study? Well, absolutely not. There's a lot of studies that go on where people are compensated for their time and for their participation, but everyone gets compensated the same, right? It's not like, just because, oh man, we need a lot more females for this study, we're going to give them extra cash in order to get them in on this. It doesn't really work that way, right? Most people tend to get paid exactly the same because they want to make sure that people don't have any undue incentive to participate, right? That's kind of a form of coercion. You don't want to do that. But the other big thing here is this provides protections for at-risk populations. So, for instance, you don't really see many studies being done, especially randomized controlled trials in fetuses or pregnant females, right? Because we know there's such risk. I just can't give a new experimental drug to a pregnant patient. You can't do that, right? Because there's such risk that could happen to the fetus we don't know about. Prisoners are another one because they are sort of a captive, in the most strict of terms, audience, where they may not have a choice, so they may feel coerced into doing that. So oftentimes you won't find prisoners being candidates for a lot of these trials here. Children can also be very tricky to get into trials, right? Oftentimes if they're under 18, they cannot provide their own consent. Oftentimes the patient's parents may have to be providing assent for them. But of course, if a child says, I don't want to do that, then you can basically, sometimes if the kid's able to vocalize that, you just don't add them into the study, right? Also, if they're mentally incompetent, that's another case where, again, putting them into a study may be, if they don't really understand what's happening, could be really problematic, and so we don't do that as well. Okay, so the big things here is just going to find that it's very difficult to include those patients in these studies because they're just at risk. Now, it's not to say they can't include that information. So, as an example, going back to, and again, I don't try to toot my own horn, but I keep going back to my research because that's just what I know. But going back to my coral snake study, now with that one, it was a retrospective case series. We already had all the data, right? We already had all the cases done at the Poison Center, so I was able to include children cases in my data because, again, I wasn't really doing anything new with them. I wasn't contacting patients. It was really just going over their charts. And so because of that, they were not putting any undue risk onto those patients. Everything was anonymous. Privacy was maintained. I was able to include those, right? And it wasn't a problem with the IRB. Similar female patients who may have been pregnant, things like that, okay? So again, there's some delineations there. It's important to understand, okay, what are the risks, what are the potential benefits, and how does that kind of go along with these at-risk populations? So institutional review boards are typically made up of several members. A lot of times they're going to include scientists and non-scientists. So as an example, you may have several different physicians or providers who are from different backgrounds working on there, but you may also have, say, members from the community, just kind of a random person who has no medical knowledge on the board as well, to kind of be that that one voice, that kind of outside of the box sort of perspective, to be like, well, wait a second, like, why are we doing this? Does this really make sense? Sometimes, when you have the scientist sort of mind, you may kind of lose yourself a little bit in terms of remembering that these are people you're dealing with and not just numbers. And so in those cases there, that can be very useful to have an outside sort of opinion. Now, how to get IRB approval. Now, let's say you wanted to do a study where you were going to be actually participating with human subjects. Basically, one, you want to make sure you're minimizing the risk to your patients, right? You don't expose them to undue excessive risk. Say, for instance, you don't. If I was trying to run a study with snake bites, I don't intentionally let a snake bite anyone, right? That'd be undue risk there. The risk should be reasonable compared to the potential benefits, right? There's not going to be one group in a study where they're definitely going to get really bad side effects and no potential benefits. It just wouldn't be ethical. Selection of subjects should be equitable, meaning that, if you have like a randomization happening there, you don't have anything preferencing, say, Caucasian patients in one group versus another, or say, for instance, children in one group or another. It needs to be equitable amongst them. And then you have to have documentation of informed consent. Everyone needs to make sure they have this, otherwise they cannot participate in the trial. And again, if they don't provide this, then they definitely cannot participate. So you have to make sure you keep all of that. Now, privacy is super, super important for this. So this kind of goes along with HIPAA information you probably have heard about before. But you need to make sure that how we're monitoring the data, how we're securing the data, and keeping privacy is really important here as well. But oftentimes, if you read these protocols, you'll find that there's a section and they're talking about where they're going to store the data and actually how they keep it secure. So for instance, when I did my IRB submission, I just said that, hey, we're going to keep this information under lock and key in this particular office, and only I have the key to it, right? In that case they were trying to ensure that privacy is going to be maintained for these patients. So looking at the levels of review, you can find that depending on the type of study, you may find that they either need sort of a full board review. Those are usually going to be much more in-depth studies, and maybe things where the risk of harm is going to be much greater, right? So say, for instance, I was going to be using a placebo-controlled drug trial. That would be something that would get a full board review. Now, if there's minimal risk, say, for instance, I was doing a blood draw on a patient, that may be under for an expedited review. It won't take as long, maybe an IRB designee would be reviewing it. And then you get into kind of lesser and lesser sort of risk for patients, and thus you don't need as big of a review. So as an example, for something that's exempt, or say this coded data one, that's kind of what I was doing for my study there, where basically I was just analyzing cases that we'd already collected at the Poison Center, and then just kind of getting the data from that. We're just kind of scraping data from those cases. And so I still submitted it to the IRB, but it did not require the same full review. Okay, so basically it's going to be based off of the risk incurred by the patient. So, as I mentioned, your research, because you're just going to be doing sort of literature review, you're going to find that doesn't really meet the definition of true novel research, because you're not really using any new human subjects. So because of that, it does not require IRB approval, which is good because this is just a semester-long class, and we don't really have the time or resources to go through the full IRB approval for all 57 of you. Okay. Now, that doesn't mean you won't ever encounter patients, even if you're not interested in research, because you may find, especially with dealing with where you're working at, you may run into patients who are on studies, right? So as an example, we have a lot of patients who are on oncology studies at Nemours, right? You'll have patients who have cancer who are on a children's oncology group or COG protocol, and they may be on experimental drugs. And you, as the ER provider, you need to familiarize yourself to know, well, what the heck are they even receiving? What kind of drug is this? Is it causing what they have that they're presenting with? Is it what kind of side effects can I expect from that? You need to be able to edify yourself a little bit there. So in those cases, you may still have some impact or some some encounters with these patients who are on studies, even if you don't do research yourself explicitly. So just as a question, kind of a thought exercise, let's say we want to design an ethical study. So I like to use the snake bite kind of example myself. So let's say we have a new pit viper antivenom, right? It's for rattlesnakes, and we want to try out this new antivenom to see maybe it's a good alternative for crofab. So one, how would you recruit patients, right? Can I take patients and just randomize them to a group? This person gets bit by a snake and this person doesn't. Well, do I just grab a snake and just have them bite the patient? You can't really do that, right? It's providing too much harm to your patients, too much risk. So frequently, we'll have to go kind of a convenient sort of approach where we will take patients who are presenting to the ER who happen to be snake bitten, right? So again, as they come in, and this is where it gets really tough to recruit for a lot of these studies, because again, it's kind of, if they're coming in, and you can get them signed up, and if not, then whatever, right? So as an example, during the summertime, we have a lot of snake bites. It'd be a good time to recruit patients for this study, versus in the wintertime, it'd be much slower because snakes are asleep and they're not around, not biting people typically, right? Now, in this case, I want to do a randomized controlled trial. Well, what is my control? Do I give the patients in the control group placebo? Well, no, you can't do that, because you have to treat the snake bite, right? So at the minimum, you'd have to do the gold standard treatment. So in this case, my control would be the gold standard, which is crofab. So that group would get crofab. The experimental group would get the new antivenom I want to compare it with, okay? And that's nice too, because then it's a head-to-head comparison between the gold standard therapy and this new experimental therapy, right? Now, could I randomize patients? Absolutely. And in fact, we try to in those cases there, where as they come in, say you have a patient coming in reporting with a snake bite, they have very obvious signs of envenomation, there's a lot of ecchymosis, swelling, coagulopathy. And we say, okay, we want to involve them in the study. Now, again, you have them fill out the informed consent. You have to let them know all the risks, the dangers, all these different things, and they sign up. At that point, you would randomize them to either get the new anti-venom, or they would get the gold standard, which is Crofab. At that point, again, if it's a double-blinded trial, the patient nor you, the provider, would know what they're even getting there. You would just basically sign up the patient. This would get sent to a research coordinator, and then they would work with the pharmacy to come up with the drug, essentially. And whatever you got back in the IV bag, you would have no idea if it was the new drug or the old drug. And so in that case, they keep the blinding, they keep the study results a little bit more safe and free from bias in those cases there. Okay. Again, how do you maintain the blinding? At that point, it's really important to make sure you keep the drug looking very similar to one another. So you can't have one that shows up bright pink and one that's clear. That would be very obvious to see which one they were actually getting there. So little things like that need to be maintained. Usually just pharmacy personnel would be the ones that actually know whether the patient is getting active drug or not in those cases there, or the gold standard. So just a little thought exercise on how you design an ethical study in a case of something where, I can't just randomize patients to either get bitten by a snake or not. That's just something you're never going to do, right? So anyway, I think that's probably it for this topic here. If you have any questions, feel free to let me know, and we'll go from there. Thanks a lot. Bye.